Welcome to the new session of the Sudanese Infectious Diseases Association Grand Rounds. It's our honor to host a distinguished global health leader whose roots and impact resonate both in Sudan and around the world. Dr. Hatim Sati is a public health physician with over 16 years of international experience in infectious disease research, health policy, and program implementation across more than 35 countries. Dr. Sati earned his medical degree from the University of Medical Sciences and Technology in Sudan, followed by a Master of Public Health from the Johns Hopkins Bloomberg School of Public Health. He currently serves at the World Health Organization (WHO) as the lead technical expert on antimicrobial resistance priority setting. He led the development of the first ever WHO fungal priority pathogens list in 2022 and the organization's inaugural global implementation blueprint on antifungal resistance. He also led the 2024 update of the WHO Bacterial priority pathogens list, which informs global research, innovation, and policy action on drug-resistant infections. With a unique background that blends clinical training, epidemiology, health systems, and decision-making research, including the use of multi-criteria decision analysis, Dr. Sati has helped shape global health priorities through evidence-based action. While with the WHO WHO regional office in Latin America and the Caribbean, he led the region's largest point prevalence surveys on antimicrobial use and continues to support countries in strengthening surveillance, stewardship, and emergency preparedness. Please join me in warmly welcoming our esteemed speaker, Dr. Hatim Sati.
Thank you very much, Azadeen, and thank you, colleagues, for the opportunity. It's really a pleasure, and I mean it when I say an honor to be presenting to some of the most experienced infectious disease Sudanese doctors. I want to first take the opportunity to really thank you, Azadeen, for this fantastic series, this all of the effort you are putting in this. This is in addition to your day job, and just your attention to details, and I've witnessed that coordinating this and your patience and overall kindness. So really, on behalf of everyone, I want to thank you very much. It's my pleasure to present to you today. I think I will start first with a bit of an overview of what we do. I currently sit in a team within the WHO HQ that is in charge of what we call the Impact Initiative and Research Coordination, and we work in various areas related to priority setting for research and development of new tools and public health interventions. And we oversee a number of also high impact research to inform the AMR response globally. As part of this work, we embarked in 2017 on the first bacterial priority pathogens list, and last year we updated the list. And I am going to present an overview of the publication that we just published in April, describing that process and method behind it, and the rationale behind the list. Can you see my screen?
Yes, we can.
Okay. And so I have no conflicts to declare. I'm a civil servant full-time. The views expressed here are my own and do not represent the WHO's official position. So starting, this is an overview of the presentation. I'll start with the background and the purpose of the list and the rationale for the update. I'll then touch on the methodology used in terms of the criteria used, the preliminary list of bacteria to be prioritized, how that came about, and who decided that. Then I'll touch on the discrete choice experiment survey that we conducted to inform the ranking and the need to fill surveillance gap. I'll touch on that as well as a consideration for the decision making. And then I'll share the results and some of the limitations and implications and the final conclusions from the list. So, as you all know, AMR is a global health emergency, and we try to describe it in those terms as this emergency is here, it's present, and it's seriously jeopardizing the progress of modern medicine. And these were the words of the Director General of the WHO in the 2022 WHO or World Health Assembly. And so AMR remains one of the most significant global health threats and one of the top priorities of the WHO. I don't know if you're following, but most recently we had a major restructuring of the WHO that basically aligned and reduced the structure of the organization as a whole from various divisions and over 70 some departments to 32 departments, and AMR continues to be a department reflecting the importance of AMR as a priority for the WHO. Of course, this is from the 2021, from the 2024 Global Burden of Disease study published last year. This study looked at or estimated the global burden of antimicrobial resistance due to bacterial pathogens, and the estimates looked at over 88 pathogen drug combination and reported that AMR was associated in that year, 2021, with 4.7 million deaths and 1.1 million attributable deaths. And in the paper, of course, that was relied on existing surveillance data and data from various sources and heavy modeling. The two numbers were indicative of two scenarios. The first scenario, 4.7 million, is a scenario where all infections susceptible and resistant to be averted. If they were to be averted, 4.7 million lives would have been saved. In the second scenario, the version only of the resistant pathogens would have saved 1.14 million. Perhaps more concerning is the forecast for the 2050 that was reported in the same paper, where 8.2 million deaths are expected to be associated with, or estimated to be, or projected to be associated with AMR, with 1.9 million deaths directly attributed to AMR. As usual, and very unfortunately, this will be shouldered mostly in low and middle income countries, Western Sub-Saharan Africa, and population dense areas of the world, including in Southeast Asia and Latin America. And so in response, the WHO published in 2016 the first global action plan on antimicrobial resistance, outlining 5 key strategic pillars aimed at addressing this growing concern. The first pillar is focused on raising awareness and understanding. The second on strengthening the knowledge through surveillance and research. The third is focused on infection prevention and control, both in the community and hospital settings. The fourth was focused on optimizing the use of antimicrobial medicines, including through stewardship and other policies. And the fifth, which is sort of the mandate that our team within the division works based on, and that is the development of the economic case for increase in sustainable investment in new medicines, diagnostic tools, vaccines, and other interventions. This plan was endorsed then by the World Health Assembly and recognized and supported through what we call now, what became or what evolved to become the Quadripartite Secretariat, which includes the FAO, the World Organization for Animal Health, and the governing body for 2026, as well as the UN Environmental Agency. This quadripartite group, of course, reflects the nature of AMR and its occurrence across the One Health spectrum. Shortly after the endorsement of the global or adaptation of the Global Action Plan, WHO developed the first bacterial priority pathogens list. This list was initially created in response to a member state request that was represented by the German government for the WHO to convene an advisory group and develop the priority pathogens list to guide research and development and other investments in new antibiotics, vaccines, and diagnostics. And the details of the study was published in a WHO report as well as the peer-reviewed publication in Lancet ID in 2017. The list at the time included 13 drug-bug combinations. Actually, it was 25 pathogens were streamlined across 13 families. And at the time, tuberculosis, a global priority for research and development of the WHO, was added to the report outside of the ranking. Since its publication, the list had a major impact, approximately 13 new antibiotics with in vitro activities against priority group or critical group of priority, the critical group of priorities have received market approval. All public funders, such as Carbex and GARP, and many private investors, as well as funding mechanisms such as the AMR Action Fund, have utilized and cited the list of the WHO bacterial priority pathogens list to inform their investment decisions. But beyond the R&D utility, the list also emerged as an instrument to guide public health interventions for prevention and control of AMR at large, with many countries and regional offices using the list to inform their action to address AMR. And so the rationale for the update came due to this importance of this tool, but also due to the fact that AMR is evolving and the very nature of infectious disease that follows, of course, a very complex pathogen ecology, people's movements of goods, and follows also a lot of the national and regional shifting priorities. The state of knowledge as well has evolved since 2017. For example, the new AMR burden of disease studies, there are lots of data that came thanks to reinforcement since 2016 to countries' capacities through the WHO GLASS surveillance platform, the Euro CSER platform, PAHO, Relavra group, which is the network in Latin America and the Caribbean, and as I mentioned, the IHME data. It also the update presented a good opportunity to address some of the limitations of the first list. The first list was largely due to the limited data at the time, was informed through qualitative criteria rather than quantitative criteria. And while the exercise really followed some serious attempt to minimize risks of bias, nonetheless, there are inherent risks affiliated with qualitative assessments, as you all know. Therefore, the working group in 2017 recommended the list to be updated every 5 and 7 years, and this was endorsed by the WHO committee, and therefore this was done in line with these recommendations. In terms of the methodology followed, multiple criteria decision analysis is the methodology we followed in the update of the list. And it's a methodology that we use heavily in our team, particularly in the area of priority setting and decision making for public health. And really around the area of informing investments. Whenever, of course, there is money involved, you want to ensure transparency and you want to minimize bias and manage really the divergent interests of stakeholders while also striking a fair and transparent balance. So multiple criteria decision analysis, or MCDAs, collectively refers to a family of methods developed to support decision making in complex scenarios. This principles, or these principles, have been rooted initially in health economics, and then borrowed in global health, and basically multiple and often conflicting criteria must be considered in decision making, and this methodology or series of methodologies provide a framework to allow for decision making. And so it was widely used in environmental management, technology assessment, as I mentioned, increasingly now in public health policy. As the goal is not to find a single optimal solution, but to systematically and transparently assess trade-offs and what you could live with, and what is the best trade-off to help decision makers make transparent and accountable decisions. There are mainly two categories to multiple criteria decision analyses. The first is value-based methods, such as the analytic hierarchy process. So you go in a step-wise approach, and you sort of assign weights to each of the hierarchies to reach a decision. And in that, under that category, you have methods such as the multiple attribute value theory, which assigns weights to criteria and score each options accordingly, as I will describe down the road. And there are other methods, including outranking methods, and it really has evolved to various techniques depending on the number of the options you're trying to evaluate and judge in terms of the decision making. For this update, as I mentioned, the decision was also beyond the utility of this methodology. We also were keen to be consistent with the first exercise, and considering also efficiency. The method that we use, particularly here, discrete post-experiment methodology, is efficient. It allows a combination of diverse criteria and data, clinical, epidemiological, and microbiological data. It covers also various contexts, community, in this case, community-acquired infections, healthcare settings, high-risk patients, also data coming from various socioeconomic setting that are varying in quality and in terms of quantity. And also it allows for the integration or filling the gaps with expert opinion. In terms of the steps, and these are overall the steps, there are a number of nuances, but you start with the selection of the alternatives and the attributes, in this case, the relevant bacterial phenotypes and the assessment criteria, which you will use to assess these pathogens against. And then we move to review the evidence to inform the criteria levels and in turn inform the assessment of the pathogens or each pathogen against the criteria. And then we conduct parallelly a preference survey to weight or assign weights to the criteria. And once the pathogens are assessed against the criteria based on the evidence and the weights are assigned, the scoring is basically done, and the ranking and validation followed by some sensitivity analysis studies. And we have worked through a protocol that we developed at the beginning of the process. In terms of the steering group included 23 members and selected observing geographic and gender balance, representing all 6 WHO regions. But we also considered the disciplines and the background and the expertise, and we tried to include clinical expertise as well as global health and microbiology and other expertise that are relevant to the process. This process was done through an open call. By the way, we received 120 applications, and this selection was done based on the criteria I mentioned, as well as the conflict of interest management, which continued throughout the life cycle of this study. So in terms of the pathogen selection, we conducted a targeted literature review or search, I'd say, from January 2017 to November 2022 to basically identify all relevant lists such attempts to prioritize pathogens for the purpose, bacterial pathogens for the purpose of informing health decisions or health policy. The search yielded 7 relevant applications, of which 6 then were determined to be relevant to this exercise, and these include the first list of 2017, as well as the Totem project, which is a Europe-focused expert consensus to prioritize pathogens or gram-negative pathogens in Europe. There is the list of Public Health Agency Canada and the CDC antibiotic resistance threat report or list, as well as the WHO India priority pathogens list. And last but not least, the global burden of disease study of 2019, and the IHME group actually were partners in this exercise, as they have provided valuable data that informed a lot of the processes. A modified Delphi survey was conducted following a number of round table discussions, and finally the consensus was to make these changes to the 2017-25 pathogens, where 5 pathogens were removed and 4 new pathogens were included, including macrolide-resistant group A strep, penicillin-resistant group B streptococci, and macrolide-resistant strep pneumoniae. And for this round, TB was defined through rifampicin resistant TB. Multi-drug resistant TB was basically defined through if you would, a peroxy, because we needed to be consistent in terms of defining all pathogens through drug-bug combinations and not operational definitions, such as MDR TB, XDR TB, etc. And so from there, we moved to then refine the criteria, or determine the criteria. In 2017, there were 10 criteria used. As I mentioned, most of these were qualitative. This time around, the criteria were streamlined to 8. 4 of these criteria were quantitatively now informed. And you see in purple, these are the criteria for which we had quantitative data. Some of the definitions were refined. For example, mortality is now defined as the case fatality ratio. We use incidence instead of prevalence, and as well as the 10-year resistant trends, we follow a new methodology. A new variable was introduced, which is the non-fatal burden, which was defined through years lost of life lost due to the burden of disease. And that replaced 2 criteria, which were largely qualitative, the healthcare burden and the community burden in 2017. The rest of the criteria were also refined. Preventability, a new scoring approach was followed. For transmissibility, also treatability, and the pipeline analyses that we use. We developed a matrix to score the pathogens across products currently in clinical development between phase 1 and up to the market authorization. And these are some of the definitions, examples of the definitions that I mentioned, mostly the definitions of the qualitative criteria. And we gathered data from a variety of sources, including systematic literature reviews and data from over 23 national and international surveillance systems, MR surveillance systems. Additionally, we incorporated valuable data, as I said, from the Global Burden of Disease group, which really informed especially the non-fatal burden assessment. Some data were also provided by the Global TB program to inform the assessment of TB, RRTB. This is an overview of the final criteria matrix, and as you see, the criterion, then the definition of the criterion, then you see the scoring system, and the scoring system basically reflects the evidence, and the range is basically reflects the evidence from various WHO regions, where in the case of mortality, for example, the bottom level for mortality was determined to be 5%. And it's defined as low across the board, while when a pathogen is associated with over 30% mortality is considered to be high. And of course, the graveness of the score is reflected through the color schemes, as you see in this table. These are some of the visual outputs that the Lancet did, and I thought it was really nice. That looks at how the criteria are assessed against the pathogens, but maybe these will make more sense here in our matrix. And so this is the step where, or a summary of the bacterial pathogens versus assessment against the criteria. And as you can see, each of the drug-bug combinations is assessed after thorough review of the evidence and also discussion of among the experts. Um, and so if you take, for example, Acinetobacter baumannii, it was assessed against mortality to be associated with high mortality, medium incidence. The non-fatal burden was leveled at medium. Trends of resistance were at level 3, which the definition here is evidence of increasing trends in 3 or more WHO regions, and so forth. And so, following this process, all pathogens were assessed against the criteria. Again, as I mentioned, following evidence first, and where there were gaps and expert opinions were then consulted. In the next step, we assign weights to the various criteria. And to determine the weights of each of the criteria, we use the paprika method, which is a discrete choice experiment method. And it's the abbreviation stands for potential all pairwise rankings of all possible alternatives. I know it's a mouthful, but it really is. It's very simple method where just for simplicity, the experts would be presented by two hypothetical pathogens. These hypothetical pathogens are described through their attributes, meaning their actual assessment against the criteria. And to simplify this, imagine you are choosing a car and you are asked to decide between two options. And us, the applicants of the survey, know both cars, but you don't. So we will refer to them as car A and car B. Car A has a better fuel efficiency but lower safety rating. Car B has a top safety rating but is less fuel efficient. And in this exercise, you are now going to rank all possible car features at once in the screen. So you are just choosing between a pairwise, between two trade-offs at the time. And these, by repeating this process across many paired comparisons or attributes, this discrete choice experiment or paprika method will learn your preference and assign weights to each features like fuel efficiency, safety, price. And so in our study, we applied this method to understand how stakeholders value different criteria, burden of disease, resistance, treatability, without actually knowing the pathogens to minimize bias that is no doubt would be associated with the process if you were to know the pathogen, depending on your area of research, of course, depending on also area of interest in terms of the work you do. The survey was conducted among 100 senior experts that met specific criteria were invited. The response rate was 80%. Overall, I think it was a fantastic response rate. And the top weights were assigned to treatability by far, reflecting the importance, of course, of being able to, most of these experts are clinicians, so to them, I think it is very important to treat these infections and then followed by mortality, to avert mortality, and then followed by the 10-year resistant trends. Together, these accounted for 47% of the total weight and really underscores the focus of these experts, but also the priorities when it comes to making the economic case for new products or expansion of equitable access to existing products, treatability, mortality aversion, and containment of resistance. The rest were more or less weighted close to each other, with the exception of the pipeline, which still was weighted higher than it was weighted in 2017. Yet this lower weight for the pipeline made us stop and think also about what people in practice truly value, and that is products that are affordable and effective and are accessible in hand, rather than future promising products. The responses were highly consistent and stable across the respondent, as it's reflected by the near perfect coefficient, the Spearman's rank correlation of coefficients, which looks at the alignment and the Kendall's coefficient of concordance, which evaluates the agreement among raters, and both have a top score scaling of 1, and in this case it's near perfect alignment. So accordingly, based on the assessment of the pathogens against each of the criteria and the weights of the criteria, the pathogens were ranked, as you can see, and scored. The total scores ranged from 84% for the top score, which is carbapenem-resistant Klebsiella pneumoniae, and the lowest, which is penicillin-resistant group B streptococci, scored 28%. Among the gram-positive bacteria, vancomycin-resistant Enterococcus faecium scored 69%, and MRSA scored 59%, making them the highest rank in this group. For pathogens commonly associated with community-acquired infections, a big highlight of this update that these infections gained high placement in the ranking, with fluoroquinolone-resistant Salmonella typhi ranking at 71%, or scoring 71%, Shigella species at 70%, and Neisseria gonorrhea 64%, which ranked highest, highlighting this growing concern of AMR associated with community-acquired infections. Sensitivity analyses revealed that while there were some differences in how experts from various regions and income levels weighted the criteria, the final pathogen ranking remained really consistent and stable and robust across all groups. You see here on the right side in the river plot some of the movement of these pathogens. You see how Shigella really leaped, and this is really, I think, was a welcome development, particularly to draw attention to these problems in low and middle income countries. Then we moved to streamline the antibiotics under families or orders, and classified each of these pathogens under 3 categories of priorities. In each of these groups, we clustered each of these these groups or families or orders based on the highest score among the family or order, and the streamlining of the resultant families and orders were assigned or designated across these priority categories based on mathematical cutoffs of scoring. And just this is the visual outputs that the Lancet kindly developed for us, and it's really nice, I think, and can be used in the future if you have any need to use these visuals. Just to be aware of them. I think they are better than our visuals. This is our visual from the report. I want to flag here, as you can see from this visualization, Mycobacterium tuberculosis rifampicin resistant tuberculosis was included in the critical group. However, RRTB was, let's say, was assessed and evaluated through a parallel process and adapted later on a process to include it in the MCDA. The reason is, of course, there are a number of nuances. Mycoplasma, Mycobacterium tuberculosis, of course, is a little bit different than these pathogens. There are a number of complexities associated with it. A number of other considerations that the global TB program flagged, including the importance of considerations around transmission and dynamics related to its transmission, as well as availability of diagnostics and access to treatment and diagnostics in various settings. Another highlight here is that third generation cephalosporin resistant Enterobacterialis are now a standalone category, unlike in 2017 when it was lumped with carbapenem resistant pathogens. I think this reflects also the nuances around both of them. And also these nuances has implications in terms of R&D and public health needs for each of these drug-bug combinations, between carbapenem resistant Enterobacterialis and ESBL producing strains. But both of them remain in the critical node. In the high group, as I mentioned, there was a movement of community enteric pathogens. One, perhaps also a highlight of this update is the movement of Pseudomonas carbapenem-resistant Pseudomonas aeruginosa from the critical list to the medium list, and there was major resistance to this by some of the experts. There was a major debate. However, the results finally were endorsed. And I think it was the right reason. But I have to stress, of course, this reduction is due in part to the reported lower resistance rates from at least one WHO region and the relative lower transmissibility and burden scoring of this pathogen compared to other gram-negative pathogens. However, of course, and this was, by the way, highlighted in the it was in line with the results reported in the Global Burden of Disease 2019, where Pseudomonas aeruginosa still was estimated to cause significant global burden, but was on the lower end compared to other major gram-negative pathogens. This shift also aligns with the CDC 2019 ranking of Pseudomonas aeruginosa as a serious rather than critical pathogen. Other changes, of course, included the removal of clarithromycin-resistant Helicobacter pylori and fluoroquinolone-resistant Campylobacter. And in their place, you have now Group A and Group B, Streptococci and Strep pneumoniae and influenza. All right. In terms of the interpretation, It's very important to stress that this is a global list that needs to be carefully adapted to local context and taken with a grain of salt and really contextualized very carefully. Regional and national certification, therefore, is encouraged in reading the list, and we have already started this process, and we are supporting a number of countries in adapting these lists to their local setting. The list, of course, is not exhaustive. Some important emerging pathogens like Mycoplasma genitalium were excluded, but they were part of the discussion. And this does not reduce the significance of any pathogen that is not included in this list. One of the important limitations, perhaps, is the nuances also that needs to be considered in contextualizing the list for R&D reason or R&D purposes. Like the different resistant mechanisms, for example, metallo-beta-lactamases versus ESPL, the impact in terms of the targets and the needs are very obvious in terms of novel antibiotic needs versus needs for expansion of existing or stewardship activities to safeguard some of the existing options. And future editions, we would hope to have enough data or tools to make this distinction. One challenge was the access and affordability of the diagnostic and treatments. When we try to consider this under the treatment criterion, data were largely varying between settings, even within the same settings, so inferences were limited there. In conclusion, sustainable investments focused on R&D for development of novel antibiotic classes and prioritize urgent global needs, particularly for gram-negative antibacterial resistant bacteria. Treatability is crucial for saving lives and controlling AMR. And that means that before thinking about new products, we need to expand equitable access to ensure access to both new and existing antibiotics coming to the market, diagnostics, and also ensuring investments in robust surveillance data, especially from low and middle income countries. And as you will see in the limitations, there are a number of limitations in the data coming from these settings. R&D is important, but we want to stress that prevention and control are key. Investing in WASH, universal health coverage, the growth stewardship, IPC programs, even expansion of vaccines is crucial, as was evident by the evidence review. And so, in conclusion, we're calling through this paper also for targeted, multifaceted interventions with prioritized set of interventions to address these pathogens. Not all pathogens require new antibiotics, is what we're trying to say here. For some, such as community enteric pathogens, for example, vaccines, WASH, IPC interventions are more effective, perhaps, and more sustainable investments for the future. And these are the key messages that you could find with the publications and open access publications, so you could read that publication. In terms of the limitations, of course, there is always the complexity and the diversity. The priority setting for global purposes is a nature of it's complex by its nature, and especially when you're looking at a wide range of pathogens associated with various risks in various settings. So it's really challenging. Data gaps, there's a lot of lack of robust surveillance in some regions for some pathogens, which affected the evaluation. For example, mortality assessments relied times on pooled data, aggregated data, leading to perhaps potential biases. Some of the community-acquired pathogens lacked updated data and reviews, particularly from low and middle-income countries, and that resulted in reliance on older data sources, experts' input to inform some of the pathogens assessments. The MR trends analysis also depended on publicly available data. There were some potentially missing data which reflects recent development, and underreporting was also noted from various regions. In terms of the qualitative assessment limitations and confirmation bias possible despite the mitigation efforts that we took, some of the criteria, like transmissibility, for example, lack detailed definition and analysis for some pathogens. And I referred to that when I spoke about how we needed to adapt a bit to consider the evaluation of TB. The data around TB transmission was just so well developed, and there was so much evidence compared to other pathogens that we could not ignore these data. Preventability focused on measures, presence and efficacy, not feasibility. This is a big gap also. And as I said, our RTB, there were a number of, to be frank, there were a number of special consideration that were given to TB that might have bumped its score, including, for example, treatability. The only guidelines that was considered was the WHO guidelines, although there were newer guidelines that had some alternative recommendations. The pipeline also for RTB considered combination therapy, and hence that was also reflected favorably in the scoring of TB. This is an overall acknowledgement, mostly for the fantastic study group that we partnered with in the University of Verona, as well as in the University of Otago in New Zealand, and the advisory group that I referred to. And of course, in this environment, I will be remiss if I don't mention, of course, the funding that was provided by the government of Austria, Germany, Saudi Arabia, and the European Commission Health Emergency Preparedness and Response Authority here. Thank you very much, and I'm happy to take any questions.
Thank you very much, Dr. Hatim. This was excellent presentation. We truly appreciate your insights and leadership in this important area. And now we're open the floor for any questions.
Hatim, this is Taha. You can hear me, correct?
Yes, sir.
Well, this is a lovely talk. Thank you very much. I learned a lot. It is not an area that I focus on it very much. I was just wondering if your office or WHO, you also monitor the reverse. For example, development of susceptibility as some older medications re-emerge, or I don't know how frequent these are. But do you also analyze the trends from the past?
Yes, this is a fantastic question. So within the AMR division, we have a team that is focused on surveillance of AMR and surveillance of use. In fact, in my past role at the regional level, I was working more on surveillance of both antimicrobial resistance and use. Now, the surveillance scheme is largely informed by the priority pathogens list and by the current guidelines. However, through a specialized group called the antibiotic group, this group was developed and now it's evolved to become the AWARE group. It's an advisory group that is focused on guidelines, and in 2022 or 23, we published the Aware Antibiotic Handbook. And basically, this group is looking into antibiotics that are listed in the essential medicines list, and how can these antibiotics be prescribed in a fashion that observes, of course, optimization and ensures that stewardship principles are followed. Within that group, a discussion was erupted about the value of reviving old antibiotics. And so this is a discussion that is really at the moment is taking shape, and there is an overall acknowledgement of the need to have a good look at some of the old options and sort of have a list that is designated at a certain, level, not the essential medicines level, but designated by the WHO as a revival list, let's say, to be watched and to be also safeguarded.
Thank you, Hatim.
Thank you, Hatim, for the wonderful talk. I salute you and your team for the great effort that you guys have spent preparing this, hugely important report. I also appreciate the fact that you guys recognize the limitations of your recommendations and call for, customization when interpreting your findings and looking at the local context and see what the local AMR patterns are and things like that. I think this is quite important. Another point I want to mention, I hope there will be some work at least in the pipeline, looking at fungal pathogens, AMR, and also parasitic infections like malaria, for instance, whether we've got a rise in artemisinin resistance. But overall, thank you very much for the talk. I find it very, very entertaining and interesting. Thank you.
Thank you very much, Zahir. And indeed, there are a few thoughts that I have. The first one is also the contextualization of the list at the national and regional level. As I mentioned, we are already starting this with Brazil, Pakistan, India already adopted the list, but we are supporting a number of countries, Japan as well, in the adaptation of the priority pathogens list for various purposes. In the case of Japan, for example, the exercise is focused on R&D, given the capacity of the country. In the case of Brazil and Pakistan is more to inform interventions and public health response. And the idea is to match this priority list of pathogens with priority interventions to address them. I have made some communications with a number of countries in the Emerald region, Saudi Arabia, and the idea was mainly Saudi Arabia and Egypt. And the idea with Saudi Arabia was to try and perhaps develop a priority pathogens list for Saudi Arabia, but it might be even more efficient to develop one for the Gulf region. And so it's something that could be a good opportunity for members of this group to collaborate and who are in the Gulf in the future. And I'll be, of course, communicating if this translates really to something next year. In terms of your point about the fungal pathogens, the first fungal priority pathogens list was developed in 2022, and we acknowledge that the list has a number of limitations, but the list was also very important in raising the profile of fungal infections and antifungal resistance. Currently, we are finalizing the blueprint, which is the first sort of strategic framework to address fungal infections and antifungal resistance in a systemic way. And next year, we'll be embarking on the update for the fungal priority pathogens list. So this is a point well taken, and we're truly trying to raise the profile of these pathogens and of antifungal resistance, particularly, which is a very complex and as you know, largely driven by, beyond the intrinsic resistance and the limited options for treatment, it's largely also driven by the mass use of fungicides or antifungal analogs in agriculture, something of a policy dilemma now, given the need for, or the legitimate need for this use for food security and economic reasons in many places.
Thank you, Hatim. I also like the fact that you guys pointed to the fact that new antibiotics are not always the right answer, and that there are other interventions that people can consider, like vaccines, like WASH and other interventions. I also want to highlight the importance of trying to influence the prescribing behavior of physicians. Looking at small stuff like maybe creating standards for microbiology reports, for instance. As you know, these have got an importance in sometimes nudging the physician in the right direction. I think maybe the focus, for all of us working, on the ground, is to think as to how we can influence the prescribing behavior of physicians by trying to, implement maybe small interventions, but hopefully they'll be quite impactful in changing the behavior. I mean, as you know, we have a mobile app that hosts our antibiotic guidelines, as well as antibiogram and antibiotic monographs and what have you. And we've noticed a significant positive impact on prescribing behavior after implementing this app. And also, we saw an improvement in our antibiogram over the last 3 years. And hopefully be able to share this, with the scientific community within the next few months, inshallah. But thank you again for the wonderful talk.
Thank you, Zahir.
Yeah, thank you. Thank you, Hatim, for the wonderful talk. And I didn't attend from the beginning, so if you already addressed this, you can just ignore my question. But my question is more of like policy and implementation related. We do face this challenge, I think, in high-income countries, but also in low-middle-income countries, that there's not really a systematic process, like what Zahir was talking about, in terms of awareness of prescribers and also accountability measures, so that we ensure if those priority lists are developed and guidelines are developed, then they're followed by implementation and some sort of monitoring and evaluation. And I just sharing a personal story, I think I might have shared this with some of the members of the group, that a couple of years ago, my dad returned to Sudan. After a very long airplane ride, he had a lot of ear pain, and he went to a local doctor who prescribed him meropenem. And the diagnosis was a UTI, so he thought he had an otitis media as well as UTI. And he had no urinary symptoms whatsoever. They did a UA that I can't remember exactly what it showed, but something showed up on the UA, and then he was diagnosed with that. So my brother sends me a picture of the vial, and they went and spent a lot of money on this vial, and they were looking to inject it and so forth. So I told them to immediately stop that and not to do this. But it was just really scary that this is the prescribing pattern of not only in Sudan, but many of the low-middle income countries, when there is no guidelines and no accountability. These things tend to happen. And now with cross-border migration and, the globe is being so small as it is, with refugees and travel, etc., it's really hard to, consolidate this into regions, because people can travel from Africa to Mexico and then to the US and to Europe, etc. So I guess, how does the WHO, how can the WHO use its powers and UN powers in terms of like being a funding agency, being an implementer or connected to these governments, to ensure that these are implemented and monitored, and that there is some accountability to these governments in terms of making sure this happens on the ground? But amazing work. Thank you so much for sharing.
No, thank you very much. And this is really a very thoughtful question, and that's really the point, right? Is to ensure that medicines are accessible and affordable, but also optimally used, correctly used. We are really discussing this extensively now, and it's been something that we've been looking at for a long time. And as it was mentioned in the introduction, we've conducted during my time in the regional office number of point prevalence survey study series in Latin America and the Caribbean, and the results were really staggering. Huh? And at the time, we have concluded that there are numbers of drivers that drive prescription behavior, and these vary from simply lack of knowledge to lack of tools, access to tools, diagnostic tools, sometimes limited access to options, as well as some perceived pressure from patients, etc. The list of reasons, of course, is long, and perhaps there are a number of experts in this group, like Zahir and others, who could speak to that better than I would. But in the coming year, we are starting a new project with the Gates Foundation. And this project will be a collaboration between our team and the stewardship team to look at this balance, how we can strike the balance between access and limiting misuse. As you know, there are a number of challenges to access also that one could argue are driving this. Not only access to medicines, but access to knowledge, access to guidelines, access to training. And so we're trying to, through this work, address root causes of access challenges. In the meantime, also inform the process, providing an operational guidance for introduction, for example, of new antibiotics, how to ensure that newer treatment options are also accessible, as well as older, but introduced in a reasonable fashion. I think also that this issue sometimes gets oversimplified, as in a way we often, or most studies from clinical settings tend to look at this from a prescriber's perspective, and there is now an also understanding that this issue is more complex, and it's related to also greater forces in terms of drug productions in the market, supply chain shortages, availability of medicines, as I said, procurement processes. In some countries that we conducted the point prevalence survey, if I remember correctly, it was years ago, but I think in Haiti, for example, the way they were procuring the medicines were largely reliant on donors and what they give, basically, and oftentimes they gave them stockpiles of medicines that's sitting around, right? And so they've used that regardless, and it's just because it's accessible. So yeah, it's something that we are working to address systematically through this project in this coming year.
Any more questions before I conclude? So thank you very much, Hatim, for the great presentation. Again, we learned a lot about the methodology, and we hope one day we can implement this list in Sudan and other low and middle income countries that in dire need for such effort. Thank you very much.